Welcome, welcome everybody. We've got a lot of really great surgical content lined up for all of you guys today. We're going to get that to really, or we're going to get to that really shortly. It looks like we are seeing a bunch of people that you guys have already joined. Thank you guys for being here. Looks like more and more people are trickling in. So I want to give it another, 30 to 45 seconds or so before we kick things off. While we wait, I just wanted to say for all you guys that are here, thank you so much for being here. This is, I believe, our third Lantern Hip webinar, but our first focused on Lantern Hip Lateral, which is the newest addition to our Lantern portfolio. And with that, we've officially rounded out the entire Lantern Hip portfolio across knee and hip. Initially, we've been seeing a lot of strong momentums behind this, and we have a goal today of just kind of keeping things simple. We want to make sure you guys can see how Lateral can fit into your workflow seamlessly. Real quick, I just want to introduce myself. My name is Jared Coffer. I'm the product manager for hips here at Ortholine, and I'm happy to be here with you. And we are joined here today by Dr. McLaughlin. He is an early adopter of Lantern Hip Lateral. He completed both his residency and his fellowship at the Cleveland Clinic and is currently practicing in Cleveland, Ohio. Dr. McLaughlin, thank you so much for being here, and thanks for providing us with this case study we're going to review today.
Yeah, Jared, thanks for having me. Thanks for everyone that's joining. Look forward to getting into some videos here, explaining what we got and answering any questions that anybody has.
Great, appreciate that. So before we jump into the case, I just wanted to do a quick housekeeping note. If you guys can use that Q&A tab on the bottom of your screen, just to go ahead and submit questions as they come up. My team over here will be monitoring them as they come in, and I want to make sure that we'll address as many of them as we can throughout the program. So thanks again for being here, and let's go ahead and jump into Lantern Hip. So Lantern Hip has three primary steps. We've got the planning phase, we've got the cup placement phase, and then we finish up with the leg length assessment. Kind of as with all things that we do here at Ortholine, the ultimate goal is to integrate as seamlessly as we can into every surgical workflow and provide meaningful data every step of the way. Dr. McLaughlin, before we get into the case study, can you just give us a little context to what initially led you to incorporate Lantern Hip into your cases?
Yeah, so two couple of things. So posterior approach for total hip arthroplasty, and then also a lateral approach for hip resurfacing. So a couple of principles I was looking for is to prevent outliers. Honestly, they're rare, but at the same time, when you leave that operating room thinking that you're in a position and that post-op X-ray is a little bit different than what you thought, trying to eliminate those cases. Trying to be really accurate with leg length. It's one of the hardest things to teach. I work with a lot of residents and fellows. Stacking those patellas without the use of X-ray and having a good idea where we're leaving the operating room with that leg length is important. Also, not being tied to a particular company. We have a two-vendor system, really three-vendor if you count the hip resurfacing, so not being attached to anything of that nature. And really, I didn't want anything that disrupted my workflow. I'm pretty confident in what I do, as I think most of us are, and so I wanted something that kind of fit into what I did on a daily basis.
Great. Thank you for laying that out for us. I think that makes a lot of sense there. All right, so let's go ahead and jump into it. Let's talk about these X-rays we got here. I'd love to hear how you plan your cases and the case that we're going to be looking at today. What are we looking at here?
Very standard left total hip was our plan. A 78-year-old gentleman, refractory any kind of type of non-operative management. So left hip, this is our plan. You can see it. This is a G7 cup and also a taper lock stem. So preoperative templating, we're looking at where we're going to put that cup, center of rotation, also from a stem, neck osteotomy standard, standard osteotomy, and just getting an idea in terms of sizes. We were about 3 millimeters long in terms of the operative size, so anywhere from 2 to 5 millimeters in length. And standard cup position is usually about 40 degrees of abduction and anywhere from 20 to 25 degrees of anteversion is what we're shooting for.
Awesome. Thank you for that. So real quick on the planning aspect, once the plan is entered into the system by the scrub tech on the back table, you'll proceed with your traditional approach. Then right before dislocation, that's when you place your pins. Is that
Absolutely.
right? So
Yes.
that's a
So
question we get a lot of steps about. Do you mind just walking us through that placement here?
yeah. So we got the first pin in here. So we're looking really superior from that greater trach right up to the iliac crest there. So you can see the palpation. So we're working down to the crest there. Um, we have a guide system that you guys give us here that really aligns these perfectly. Two small poke holes. This second pin is going right into that iliac crest. I want to make sure that I'm perpendicular to the ground, making sure that the navigation system is when it goes on is really perpendicular to the ground, and you kind of see that as we're going through. So the two pins are in. This is our housing unit. Think about an X fix about 2 finger breaths above the skin. That's going to get locked in position. And then when the nav unit comes on, as we're going through this, you're going to see that there's a little bit of movement that I can position it where I want. What I'm thinking about here is restoring that coronal plane or trying to register that coronal plane. And I'm thinking about that being perpendicular to the ground. That's coming off at about a 45-degree angle. And I'm going to lock it in that position there.
Perfect. Yeah, thank you for that. Another question that we get quite often is how your patients kind of perceive the step. Do your patients ever say anything about the extra incisions or anything like that?
Talk about it pre-op. So we just say, hey, you're going to
Mm.
have your standard incision. Then you see these two small poke holes up here. Absorbable suture, dressing goes on. Really not had any issues. It's not like we're doing any kind of bone grafting, harvesting, or anything of that nature. So I haven't honestly seen any issues with the type of infection or pain from that area.
Okay, cool. Thanks for clearing that up. Appreciate it. All right, so right now we got our pins. They're in place. You've locked the lantern unit down. Let's move on to the registration phase. So I'd like you to do you want to walk us through this step here?
Yeah, so we got so here we're getting that coronal plane. You can see that diagram that we created on the right side there. So we're trying to register the patient's coronal plane. I'm looking to make sure that I'm stacked to the ASIs. Here we're getting a plane down the length of the femur. This is how we're going to judge or another tool that we use in terms of leg lengths. That's the way we're going to either shorten or lengthen. And here we're getting that first tack position. So the tack is already on the vastus tubercle. We're registering that tack, transferring our sensor down to the leg. So this is our registration, and we're going to be done right about now. So we're done with registration. We have our nav unit in place. We have our starting leg length from what we started with, and we have some data points that we're going to reference in terms of our abduction and anteversion. One of the things in terms of those planes is, the coronal plane that we give it, a perpendicular plane that the nav unit establishes from there. You think about like accelerometers or gyroscopes that we have on our phone. A lot of those things that are used in this technology to help us guide the angles that we're looking for. And we'll kind of see that as we go here.
Great, thanks for that. So this real quick, this video was like, I don't know, roughly, I think it was like 55 seconds or so. Is that pretty typical of what you see as far as how long it takes you?
Yeah, I think that's pretty accurate, right? Maybe slowing down a little bit for video purposes, but that's pretty accurate. You can just see the time that it took.
Cool. All right, cool. Thanks. So we've got the registration done. Then correct me if I'm wrong, but you're going to go through with your dislocation, your femoral arthrotomy. You'll go into your acetabular preparation, and then it's time to place the cup, right?
That's it. Exposure's already been done, and then registration has just been done. Obviously, now we've already made our neck osteotomy. We're reaming our cup, what we planned in terms of our position. And here's really where Lantern really plays into effect. So we're taking that cup down. I do it in twofold. Anybody can do this in whatever way that they want. So I'm going to have my initial cup. I'm going to go about halfway down. I want to see where I'm at and get my initial reading. For my purposes, I like to roll those ASIs back to be stacked. Why is that? It just for my preference, my idea that I have the ASIs that are stacked, and I'm looking at my handle. If you don't want to do that, you don't have to. Lantern will correct about 15 degrees and it'll show you in terms of tilt, either anterior, posterior, or superior, inferior. And the number that you're getting is what the accurate number in terms of the cup placement is. So this first cup went down. I think we were a little bit under anteverted. I think we were at about 19 degrees. Can we see a little bit of live tracking there? Maybe it's the next one.
You want me to move on to the next one or
I think we're moving on to the next one where we show a little bit of,
sure, yeah. So this is the second time that this is the verification that you do.
yeah.
Um, so we can go into that.
Yeah, so what we did was we put the cup down. We needed to add a little annoversion. It's going to give you live feedback. So I'm kind of just keeping my same abduction, adding a few degrees, and then taking the instrument or taking the handle down all the way, cup position, making sure that we're all the way down. And then here I'm going to get that final reading. I think we are at like 40, 22, something in that realm, which was acceptable. Everything looked good to my eye too. And so here's our final reading. We're in a good position. So we're happy with where we're at with the cup, and we're going to be done with we register it, and we're going to be done with this part now.
Perfect. Thanks for that. Yeah, I guess I'll just give a little bit more context to the rotation aspect that Dr. McLaughlin was mentioning on the bottom right of the cup measurement screens is the system will track the rotation of the pelvis in real time and the tilt of the pelvis in real time, and will adjust your cup numbers based on that. That's what we were talking about on that first one. So that's something that we see a lot, right, Dr. McLaughlin? If those heavier tractors go in from big Cobra retractors, it's easy for the pelvis to shift anterior and
Excellent.
posterior quite a bit.
Yep. So anything that list get or that leg, the listing the pelvis to the forward, the retractors going in. But there's a lot of information that's really valuable. What you registered, you're getting back to that point if you want to, or it's showing you how you've changed and the reference point for the cup positioning from there.
Perfect. Cool. Well, thanks for taking us through the cup measurement there. I think that was a good example of how you got the cup into position and then you verified your final position. So thanks for walking us through that. Appreciate that. So now that we've gotten our cup, the next step is to place the liner and register the liner. Do you mind walking us through this quick step?
Yeah, so osteophytes are out right here. So that poly's in there, final poly. So we're going to put this inside. We can do anywhere from a 28 to a 44 head or a dual mobility. This is just a tool that we're using in terms of getting that center of rotation, helping with the accuracy of the leg length. So that goes on to the pointer, and then we transfer our sensor, and we register that position. So now the nav unit knows exactly where the center of rotation is of that cup, and we're going to use that as a tool for our leg length.
Perfect. Yeah, and like Dr. McLaughlin said, this is just an extra step for measuring that final leg length, and this supports all liner sizes. I believe, did you put in a 40 liner on this one,
I
on
think
this
we did, yeah.
particular case? Yeah, so we can go up to 44 and then all the way down to dual mobility sizes. So thanks for clearing that up. So after that, you've it's time to broach the femur, do all of our femoral preparation. So I'll go and punt it back over to you to walk us through that.
Yep. So just standard broaching from where we're at. Sorry, I just got kicked off here. So standard broaching from where we are. Hold on, Jared. Can you still hear me?
Yeah, we can still hear you.
I apologize. I just got my work computer kicked me off. All right, back at it. All right. So broach goes in. So there's a thigh plate at the bottom. That's where our original sensor was. We have a reduced hip right now with our trial broach and trial head into place. So I'm going to get some information. Usually I like to take it through my stability testing first. I'm going to get an idea in terms of leg length of what I feel. Those stacked patellas, I'll take a look. But now that arm is back into the tack, this is our original registration position. So we're going to start there, and then we're going to transfer the sensor down to that thigh plate. This is all the same position that we initially started with, and I think we came up with a leg length of a couple of millimeters under,
Shorter.
right? So there we go. So what we're using here is we're thinking about that broach. Where does my implant sit? Some final implants sit a little bit higher, depends on what system you're using. Some sit exactly where you're at. The other part of that is, the different options of head options. Do I have the head options to go up or down as I would need, which I think we were in a good spot with this.
Perfect. So I believe in this case you did just the initial trial reduction, and then we did the final stem and another, and I guess another. I can't remember exactly. I think we just did two reductions. We put the final
Yeah.
pieces in, and then we did one final reduction. Is that kind of your typical standard workflow, or how many times are you doing your reductions?
Yeah, that's it. So we got the trials in. We're in a position that we can adjust in terms of head sizes. So we'll dislocate, broach comes out, head comes off. Final stem goes in, and then we'll trial one more time with in terms of the heads that we want. So I think we set up a few millimeters with the taper lock, which is pretty standard. And then we went up to a standard head and obviously taking it through those posterior stabilities, anterior stability, shuck, and then looking at the leg lengths. And I think that we ended where we wanted to be. We wanted to give them a few millimeters, and I think that's what we ended up doing. So we're going to do exactly the same registration again. So we'll bring the nav unit back in the final time and get a reading. Again, we're putting that arm right onto the tack, same position we registered. We're going to get the information, making sure our patellae are stacked there. That's what you're seeing. And here we go with the tack. And then we're going to transfer the sensor down to the thigh plate. And it's going to give us exactly where we're at with this time. So if I like all the stability, I like what we've done with leg length, then we're good to go. We're going to dislocate one more time and put our real head on and be good to go and close it up.
Perfect. Yeah, so you close up, take the pin out, take the tack out, and you're
Yeah,
done, right?
so yeah, that's one thing that really right after the final implants are in, my mind goes to taking the tack out and taking those pins out. We don't want to leave anything in the patient, and just that's exactly what I do every time, making sure that those come out right away.
Perfect. Cool. Well, that was great. Thank you for again, thank you for allowing us to videotape this. I think this is a really great kind of case study on just kind of the workflow of Lantern Hip, and how it gets all those valuable pieces of information like your cup values and leg lengths. So before we go on to some of the Q&A, I just wanted to put a slide up here. I know we all love looking at X-rays, so let's go ahead and just review our final post-operative X-ray, and I'll turn it over to you and see if you have anything else that you'd like to highlight or about the case.
Yeah, so nothing stands out. We put the cup in the position that we thought we had good information. That's exactly what we see. This is a supine post-op X-ray. We obviously this was just done last week, so we haven't seen the patient back in the office for a true standing AP. But again, we added a few millimeters of length, and I was happy with where we ended.
Awesome. Cool. Well, thanks again. That was great. And with that, let's go into transition. We've got a little bit over 10 minutes, so I think we're going to have a healthy Q&A session. I am seeing some questions come in already. Before
Absolutely.
we get to some of those questions, let's go ahead and move on. I just wanted to remind everybody where you can submit your questions. While those continue to come in, let's see. I just wanted to mention there's going to be a brief post-webinar survey after we wrap up. So if everybody could just take a couple minutes, I think it's like 5 or 6 quick questions. This will allow us to continue to bring you guys these programs, some educational content on everything Lantern here at Ortholine that we offer you guys. So go ahead and submit your surveys. We appreciate all the feedback. So got a little bit more questions coming in. Let's go ahead and get to one. There's actually been a couple other questions about the pins. As far as the iliac pins, when you vertically position them, does that affect decisions surrounding cup placement?
Um, I'm not sure I understand the question,
Or
but I'll
sorry,
try to.
that was the follow-up question. So it was back to the pin placement technique. And if this affects movement of the patient or other parts of like, so do the pins in the crest have any effect on any other part of the case? Like, do they get in your way, or anything like that?
No, they're pretty far up there. Obviously, the iliac crest is pretty far away. I have not had any issues in terms of retraction. A lot of the times you saw when the unit was brought in, we're registering or we're getting our data points and figuring out exactly where we are. We're not usually having a lot of retractors in those scenarios, except for maybe the cup. But again, I didn't feel like it gets in the way. We don't need to use any type of laser anymore, so it's really an easier workflow, to be honest.
Perfect. That actually sets us up really nice. There's another question that just came up. Were you a former OA user? I know you just mentioned the laser. Can you talk to us about how Lantern Hip Lateral compares to the Ortholine Plus unit and the Hip Align days?
Yeah, I think that registration is the most important part of when we use these tools, right? Garbage in, garbage out. So the more we're able to reproduce the registration points, I think we're just going to be driving accuracy. And it was tough from those experiences sometimes, especially with the larger patients, to get back into those registration points. You could, but it was much more difficult than what we're doing right now. I think you saw from the video, again, there's no laser involved. It's really that arm that's coming down. The arm is pretty reproducible. The tack obviously stays in the same position. I think overall the workflow is easier and more accurate.
Cool. So yeah, everybody go ahead and keep submitting the questions. I've seen a few more come in. Just real quick, I wanted to point out on this slide, this shows all of our sales leaderships across our sales leadership team across the country. Feel free to take a screenshot of this slide here. Reach out directly to your local representative. We're happy to give you more information. And then we all know that AAOS is right around the corner in a few weeks. We'll be at booth 3739. We have a few live demonstrations for, I guess, one lantern knee and one lantern hip, one scheduled, one with Dr. McLaughlin, and then another with Dr. Kagan for knee. And then we'd love for all you guys to join us and come see us at Felix's restaurant on Bourbon Street. So come on by. We'd love to see you, and we're excited about this event. So, all right, so let's get back into the Q&As. Let's see. All right, so it seems like we might have some surgeons that have experience with some of those larger robotic system, the console robotic systems. Can
Yeah.
you give us an idea of like the value of Lantern Hip in comparison to those and why you choose to use Lantern Hip?
Yeah, so it's not tied to a particular implant, right? So you
Mhm.
might be going to different hospitals, ASC versus hospital-based, different hospital systems, depending on your practice. So you're not tied to those. You're not committed to in terms of volume, right? So that's one of the things that we deal with a large academic institution is we get committed in terms of volumes with those large capital expenditures. Ease of use, it takes me much less time for registration, assessment at the end than a lot of the other systems that are out there in terms of robotics. It's much less data points that I really don't know if help with everything that we're doing. So I guess just time efficiency in the OR, and a little bit more ease and really not being tied to a particular implant during surgery would be the answer.
Perfect. Yeah, I think that's a good answer. I guess tied to that question a little bit, there's a couple questions about the ASC.
Yeah.
What are your thoughts on Lantern's suitability for the surgery center?
Yeah, so you're looking for efficiency, right? You're looking for a low amount of trays. You're looking for quicker turnovers. You're looking for things that are predictable, and that's exactly what it offers. I can take it from in my practice. I take it between two approaches. I take it between a lateral and a posterior approach, and I take it between two implant companies for that, right? And that's one tool, or in this case, a navigation unit that accomplishes all that. And I didn't really have to change a lot of the way that I did surgery to adjust to the tool that I'm using, right, which I liked.
Perfect. Thanks for that. So another question that we're seeing. So as far as we're getting kind of questions about those first cases, kind of learning curve. How many cases do you think got you through your learning curve? Maybe some tips. We'll start with that. How many cases do you think it took you to get through your learning curve?
Yeah, I think that you're going to be feeling a lot different by case five, right? You might even be case three. Um, if you look at that video and just have an idea where those pins go in and getting that nav unit in the right position to start with, which I think is pretty easy to once you get the hang of it. Um, there's apprehension. I remember the first pin I put in a iliac crest. Yeah, there's apprehension. We don't normally do that. We stay way out of there, right? Once you get 3 to 5 of those under your belt, I don't think that there should be much apprehension. You're feeling that iliac crest with the tip of those with those pins, and there's a guide to it, and I think it's pretty easy. So I don't think that there's a significant workflow disruption from what you're doing now.
Perfect. Yeah, I guess one thing that we didn't mention in the cup aspect of things, but we have little adapters, and if you look closely on the G7 adapter, we've got an adapter that fits onto that G7 implant handle or the adapter handle, and we've got a whole host of adapters that are available for almost every single adapt implant company out there. So, like Dr. McLaughlin said, we really pride ourselves on being able to be used with every implant. So again, just another follow up on kind of those first cases. Was there, I don't know, is there any like kind of tips and tricks that you would suggest for those first few cases?
Yeah, trying to when you register your the system the first time, I like to get back into that position, not so much that from a standpoint of the navigation unit, but for my own eye, right? Because that's what that we're using this system, Lantern, as a system that I'm back in the position that I initially assessed the patient. So getting back into that position, even if you're not, say you're still anterior tilted a couple of degrees, just as we were with that case, you're superior, it's making the adjustment to make sure that you're accurate with the numbers that you want, right? You get a larger patient, that pelvis gets pulled over a significant amount, say it's 10 degrees, that's a significantly different cup position than what you had. And I think that's when we have our misses, it's when we're losing the perspective of where we're at in
Hmm.
space, right? Because you got a lot of soft tissue that you're dealing with. So this is going to be one, you can look at it and say that, yeah, I'm reasonably back in that position. It's perpendicular to the ground or pretty close. And two, it's correcting for where the pelvis started and where I'm at now. Um, and the other thing is the leg length. I think the leg length is pretty easily restored. One of the things that we talk about is offset too, right? And so in terms of offset, we don't have any type of readback or feedback on this, which I don't really think that you need, right? So you position those implants, you have a pre-op plan of where you're going to put them, you put them into those positions. If that leg length is accurate and to down to a few millimeters, and so you put your implants where you want them and your leg length is where you want, you got a pretty good chance that your offset's going to be exactly what you want to. Because that's what every surgeon worries about, leg length and offset. Those are the hardest things to reproduce. And so if you're getting a lot of information for a lot of it, I think you're going to be accurate in the end.
Perfect. Thanks for that. Going back to the pin sites, what is your like kind of wound management, Steris type of glue, stitches? What are you typically doing?
Yeah, so we put a like a deep little suture, one in each of them, and then we do like a nylon suture, just one through the top, and then we'll put a some type of Methyl X dressing or whatever on there. Comes off at the same time that the dressing comes off, usually about 7 to 10 days. Obviously, if there's any kind of drainage, recover it and let us know. But rarely that there is, but comes off the same time as the incision in the standard incision, and then suture comes out times two clips at their first post-op, which is about 2 to 3 weeks.
Perfect. Thanks for that. So looks like we're kind of wrapping up here on time. We got 2 minutes left. I did want to say, first of all, Dr. McLaughlin, sorry, you just agreed to. You told me today that you were going to be at our event at AAOS at Felix's. I don't have your name up here, but Dr. McLaughlin will be there, so we're excited to see you there as well for Felix's. So thank you for joining us. We want to see everybody there. Come by, say hi to us. Sorry, one more Q&A. Looks like, is there a video that I can access for Scrub Tech setup? Yeah, I'll take that one. So we have a couple video pieces of content that's available up on YouTube. I'll send that in an email to all you guys after the case. So be looking for that. So all right, Dr. McLaughlin, any final thoughts
No,
before we
thanks for
sign
having
up?
me. I enjoyed it. I look forward to meeting anybody, answering any questions at the events.
Perfect. And then just real quick, we'll follow up with everybody else. I know there's a few more questions out there. We'll make sure you guys get all of your questions answered. Um, Dr. McLaughlin, thank you so much for being here. Thank you for giving us a glimpse into your operating room, walking us through the case study today. Truly appreciate that. We really appreciate everybody else that joined us on the call. We look forward to seeing you guys all at AAOS. Please come connect with us and reach out if you have any other final questions or comments or anything like that. All right. Well, with that, we appreciate everybody's time. I hope you guys all have a great evening, and we'll see you all soon. Thank you so much.
Uh, Thanks, everybody.